So you just missed the introduction, but that's fine. We're just talking about the different kinds of things that we will be dealing with during today's presentation. So are we entering a new COVID wave? That seems to be the question. It has been relatively stable most of the fall, but it is on the rise again. And it's on the rise in different parts of the country. In the past 2 weeks, COVID-19 cases have jumped up more than 25%. Now realize that we've been at a very low starting point. So a 25% increase sounds like a lot. It is a lot. It is a warning shot, I think, across our bow, but we're not to the point where our hospitals are full of COVID. Right now, our hospitals are full of the flu. Test positivity rates, ICU admissions, and the level of virus detected in wastewater, which is a great way of seeing really what's actually in the community, are increasing. And so we may be entering a new wave. You can see that during January of last year, we had an enormous spike in the number of cases, over 700,000, close to 800,000. We're really only around 53,000 now, but it is beginning to tick up. The rise in cases and hospitalization is worrisome as we go into winter months because we are indoors more, even in the South. We're indoors more. We have holiday seasons together. We have Christmas, we have New Year, we've got Hanukkah, we've got all the different holidays that are out there coming together, and it's a great time to be with family. And we hadn't had a chance to be with family for some time because of COVID. So there's a lot of people that are traveling and getting together. The timing and uptick of COVID activity is also concerning that many health systems across the US are already dealing with patients stricken with RSV and influenza. Our RSV is primarily impacting children. I work at Grady Health System in Atlanta, which is one of the largest public health hospital systems in the country. We have a children's program as well, a children's hospital, and the hospital has been actually full of children with RSV. As we like I mentioned earlier before the recording, was it the gathering of Thanksgiving that contributed to this rise in COVID cases, or has it changed as to the virus? And the virus continues to mutate. But what's interesting is it's not necessarily a new strain. So we had Alpha, we had Delta that we were dealing with for a long period of time that was causing a lot of very serious illness. We've had Omicron in place for quite some time at this point, and we know it is more contagious, but it doesn't cause a more severe illness for most people. And so that's a bit of a positive. So we have two subvariants and another one on the way, BQ1 and BQ1.1. They are variants or subvariants of Omicron. So they are more contagious. They are able to evade vaccines to a degree. They also can escape monoclonal antibodies. The treatments aren't as effective, but the disease isn't severe enough. And I think as severe as it was with, say, Delta. They account for 62% of cases nationwide. This really large chart shows you how the virus has actually changed over the period of time. So you can look in September and you can see that BA.5 was by far the predominant subvariant that we saw. Those numbers are going down, and it is predominantly BQ1 and BQ1.1. Same blue positive for me already. Yes, I will talk about that because the flu is really nasty this year. I was looking at the chat. So you can see that BQ1.1 and BQ1.1 are doing the predominant amount of cases. It has been on the increase all summer long into all fall long. But there also is another one out there, BQ2.75, that could be another bit of a problem. So really what we're seeing is not more severe disease. Our hospitals aren't full of COVID at this point, which is good news. But we need to still keep our guard up. And that concerns me that when I travel, and as I mentioned earlier, I picked up a RV in Prescott, Arizona, absolutely gorgeous place. Traveled across the US, and since I was in an RV, I think I hit Walmart more than I actually have hit in the last 2 years combined. But you would see there were very few people that were masking. What was encouraging, though, is the people that were masking were older and predominantly minorities, and they're the ones that have really, when I say they're, because I'm older now, but we're the ones that are more likely to have a severe disease or severe problem with it. There we go. So the bad and the good, as opposed to talking about the good and the bad, I sort of changed this up. They're more contagious than Omicron BA.5. They're even more immune evasive, as I just mentioned. This means that new variants can bypass immunity acquired by vaccination. They can bypass natural immunity and treatments and prior infection. But he's optimistic that these two variants won't have as severe an impact as previous variants based on other countries' experience. Remember, we get things a little bit later. We look for signs in the Southern Hemisphere for flu. We look at signs in Europe for what we're going to be seeing with COVID. I think the wild card that we're going to be dealing with now is that China is lifting its zero COVID policy. And what will that mean? There is the most populous country in the world, India coming in number 2. And if don't have a lot of natural immunity and their vaccine, they did not use the mRNA vaccines. Their vaccines are not as effective as the mRNA vaccines or even our protein-based vaccine that we do have out there available now. That what is that going to bring? And so I always think we need to keep an eye on it, and it's better safer than sorry. So the bad news is that we have this new variant. They are more contagious. The good news is it doesn't appear that they're going to cause as many hospitalizations and serious illness unless you are, 1, immunocompromised, or 2, that you're older. And I think those are things we need to watch out for. As of December 1st, 2022, and I look at the community transmission levels. That is basically, I think, one of the most important areas. And I'm going to show you during this presentation how you can check out specific areas in Arizona for COVID levels, for RSV levels, for influenza. So there are ways of checking all this out on the internet. And the information from Arizona, of course, comes from your Department of Health. As of December 1st, 2022, 5.7% of the counties, districts, and territories had a high COVID-19 community level. The last presentation I did a few weeks ago, regretfully, that number was just 2 point something. So we are seeing a big increase. It's still a small percentage, but it's a big increase where there are high community levels. There are 24, almost 25% have medium community levels, and the majority, 70%, have low community levels. So when the community level is low, of course, you are less likely to be exposed. Compared with the previous week, we can see there's been a 2% increase in the number of high levels, a 6.5% increase in the number of median levels, and a decrease of 8.5 in the level of low level of incidence. Overall, 46 out of the 52 jurisdictions had high or medium level counties this week. So it's spread across the country. But unusual, I'd say this is an unusual map from the Southeast perspective. As I said, I'm in Atlanta. And if you look at HIV in the Southeast, you know that it is completely out of control. Florida is the number 1 state for new cases. Georgia is the number 2 state. I believe Atlanta is the number 1 city. But if you look at COVID transmission levels, green means the levels are low. Yellow means the levels are medium. And regretfully, orange means the levels are high. And so if you look at your state, there are a lot of medium and high areas. And in my state, there are just a few areas of medium, which is really, like I'm saying, in the South, we have a weaker public health system than many other parts of the country, but right now we are not seeing it. And is it because we still are outside, we aren't inside? But Arizona is a nice warm state. It's like Florida where I grew up, except a lot drier. So I don't know why we're seeing this, especially what we're seeing in the Four Corners. So I don't have the reasoning for that, but I can tell you that it's there and we need to be cautious. If you look at the daily update for COVID cases, you can see that the weekly total was 303,000. The deaths are going down, and that is wonderful news, down to 1,700, but we have lost over 1 million people to COVID since it was first discovered late 2019, 2020, early 2020. When I try to put this in perspective, because I worked in HIV almost my entire career, well, my entire career, we've lost around 600,000 people in the 40 years or so since HIV was discovered. We've lost 1 million people to COVID, and that is frightening numbers. Hospitalizations are definitely, the trends are going up, but they're still relatively low. There are about 30,000 people who are hospitalized around the country. Vaccinations with updated boosters at 12.7%. I think there is a really hard, not with this patient population that I see and not with my staff that are around my age, we jumped and went and got the booster. But when you look at people, I think are boosted out. When there was a statement July 4th, I don't know if it was, I guess it was last year or year before, that if you get vaccinated, you can take your mask off, you're going to be fine. That wasn't a true statement, because basically this vaccine does not prevent infection. What it does do, it prevents serious illness and hospitalization. And those things are very important. So when you look at total up-to-date boosted people that are over 5, and now you can actually get boosted at 6 and younger, it's about 39,000 people. So 39 million people, I'm sorry, 40 million people. We really need to work on getting people up to date with their vaccinations. We also know that it is important when you're getting your booster that you have enough time in between the shots. So if you get your first 2 doses, say 3 to 4 weeks apart, depending on if it's Moderna or Pfizer, after you get your first complete series, then you need to wait 5 or 6 months until you get boosted. Arizona community levels, again, this comes from the state health department. Your 7-day metrics, there were about 13,000 cases of the tests that were performed, and this is just tests that were performed in hospital. These doesn't count the tests that are done at home. So as I mentioned earlier, I got the flu. I didn't know if it was the flu or what it was, so I had COVID tests at home and I was testing on a regular basis. So I didn't test positive, but had I tested positive, I would not have reported it to the state. There's no mechanism to do that. So these are people who are getting tested where they can report to the state. 25% of the cases were positive. There were 42 deaths in Arizona. The percent of the population 5 years of age with completed primary series is 70%, and that's pretty good. But that's just the primary series. Those are the first 2, as they say, jabs, although I don't like that term. New hospital admissions over a 7-day moving average is about 181. So let's look at the map. You can sort of tell here the percentage of who have completed the primary series around the United States. And if you look at the draft, the charting up here, you can see the Southeast, except for Florida, tends to have the lower rates. That sort of fits with what we see in the Southeast on other issues as far as health goes, but it also is hitting areas like Illinois and Missouri. So we need to be a little bit more careful about that. But Arizona, again, over 4 million, close to 5 million people completed the primary series. So it was about 66%. And you can actually click on the map and find out more information. So you can see the Northeast has higher numbers of people who completed the primary series. Hawaii had more numbers, but when you get up into Montana and North Dakota, those numbers again are low. If you see who's received at least 1 dose by race and ethnicity, you can see 44.5% are white non-Hispanic, 20.7%, are Hispanic or Latino, other race 13.4%, unknown about 10%, etc. And then when you look at male or female, they're about equal in their numbers, with females usually performing better than men, or more willing to move forward than men. Men are not the best when it comes to healthcare. I'm still working on it as I approach 65. What about long COVID? There are two studies that I'm going to talk about. One that was actually a Scottish study, and they looked at 100,000 participants, so it was a very large study. And there's evidence that many people do not fully recover after being infected. One of the things that we do know is if you have a mild case of COVID, the chances of having long COVID are greatly reduced. But if you have an acute bout with COVID, you're hospitalized with COVID, you have serious illness with COVID, the chances of having long COVID are greatly increased. The study found that between 6 and 18 months after infection, 1 in 20 had not recovered, and 42% reported partial recovery. There are some reassuring aspects to it. People with asymptomatic infection, like I just mentioned, were less likely or more unlikely to actually have long COVID, and vaccination offers some protection. The booster seems to offer even more protection, this bivalent booster. But again, this bivalent booster is not going to last a full year. So when you heard promises about this one booster lasting for a whole year, mRNA vaccines really sort of peter out between 5 and 6 months. So what are we going to see in 5 or 6 months? We'll be in summertime. Hopefully we won't have another big jump in the July time. So, and another study and the same study, I'm sorry, that was between Mount Sinai in New York and the University of Glasgow. They emphasized and revealed a wide-ranging impact on long COVID people's on life. There are lots of different impacts going on as far as quality of life, employment, schooling, and ability to look after yourself. And this was published in Nature Communications. Previous studies have been challenged by the non-specific nature of long COVID because there are so many symptoms that we've been seeing. Breathlessness and fatigue are also common in the general population. There are people with COPD, people with heart conditions, people who are out of shape. I'm one of those. COVID in Scotland study, which included a control group, was able to actually pinpoint what were we seeing. And those who had COVID were significantly more likely to get 24 of the 26 symptoms studied compared to the never infected population. For example, those who were infected were 3.5 times more likely to be breathless. In the United States, the range of reported symptoms and ability to provide a prognosis for patients have perplexed researchers and ones that I work with on a daily basis, even as the breadth of the challenge has become clear. There's a person I work with on HIV advocacy, Julie David. She's in New York. She is actually one of the more brilliant people I've worked with over the years. She is completely incapacitated. It's just so awful to see someone who was so vibrant, who had a serious case of COVID, who now can't even stay on a call for an hour because she runs out of breath and is exhausted. Between 7 million and 23 million Americans, including 1 million who can no longer work, are suffering from the long-term effects of infection. So the goal is to not get infected, or at least to stay up to date with your vaccine. So if you do get infected, you don't have a serious illness or hospitalization. There was also research done in the United States between physicians and researchers at Kaiser Permanente and the Mid-Atlantic Permanente Research Institute and Johns Hopkins. They identified 17 conditions associated with long COVID in order to better diagnose and treat the condition. There's the name of the study, and I'm going to go over the different conditions that they had. Again, this was published in Nature magazine. The research looked at the medical records of over 100,000 Kaiser Permanente Mid-Atlantic State adult patients, over 30,000 who tested positive for COVID-19, and over 70,000 who tested negative for COVID-19 in 2020. The 17 conditions are in front of you. I'm not going to read them all, But diabetes is something that we need to look out for. And as dental healthcare workers, we know that there are a lot of people out there who have undiagnosed diabetes in the United States, or they're pre-diabetic. So one of the things I really advocate for, and we'll be advocating for at Thrive Live this year, which is a Henry Schein conference in Las Vegas, is doing point of care testing or point of care screening. And it really depends on your scope of service. I understand that. I am on the Georgia Board of Dentistry, and I'm working to make sure that we can screen for certain conditions such as HIV, diabetes. Of course, we should take blood pressures on everyone that we see. Patients in my area where I live tend to have hypertension. And if it's out of control, we can actually communicate directly with primary care and make sure we can get them under control. And we have that on a regular basis here. Luckily, I work in a very comprehensive program for people with HIV. We follow 6,600 patients. So we have primary care, we have research on site, we have women, family, children, and youth programs. So if there is somebody who has, when we take their blood pressure at every visit, if it is high, we can literally get them set up in our acute care clinic that day and get their medications looked at or changed. Some of the others that are out there are non-specific chest pain, some mental health and anxiety disorders, GI symptoms, fatigue, which we mentioned, cardiac dysrhythmias. I mean, basically everything. Remember, we had a loss of taste and smell. Those were some of the earliest signs that you might have COVID at the very beginning. Nutritional disorders. I mean, it almost covers just about everything. But there is some new light. Researchers were more interested in conditions that developed in their patients within 30 days of a positive test and persisted for nearly 4 months post the test date, and conditions that developed in the 30 to 120-day period after a positive test. The key conditions included loss of smell, cardiac dysrhythmias, diabetes, GI issues, fatigue, and chest pain. The researchers used Kaiser Permanente's EMR to categorize conditions into 3 distinct time intervals based on when a patient tested positive. By organizing the conditions by date of when a patient tests positive, researchers were able to effectively evaluate resulting symptoms that were related to long COVID as opposed to being caused by pre-existing health conditions. By comparing COVID-19 patients to COVID-19 negative, the control group, researchers were able to tease out which symptoms appeared more often in the COVID positive group, which symptoms occurred more often in the COVID negative group, and which symptoms appeared the same in both groups. Overall, 16.5% of COVID positive patients within the study developed at least one long COVID related condition with 120 days of a positive test. This finding is lower than the national averages, which show that nearly 20% of American adults who've had COVID report having long COVID symptoms. So when they did the study, it was a much smaller percentage, well, not much, 16.5%. compared to the 20%. So that is 1 in 5 who have had COVID who are reporting long COVID symptoms. The best thing to do is avoid serious illness and protect yourself. Researchers found that some patients may have developed diabetes after COVID-19. Now, is it actually developing diabetes after COVID-19, or was it undiagnosed before? As I just mentioned, there are a lot of people out in the general population who appear perfectly healthy, who don't have dry mouth or frequency in urination or any of the things that might lead us to believe they have diabetes. They may be overweight, they may not be overweight. So it may be just undiagnosed diabetes to start with, or is it related to the COVID-19 test? And so we really don't know that yet, but it's something that we're looking at. It's possible that some patients were just simply undiagnosed and sought care for COVID-19, or they were being admitted to a hospital for a different reason. Our hospital just recently stopped testing everybody who was admitted to the hospital for COVID, since we have maintained our strict COVID protocols. We have not changed them here. I mean, yes, we have visitors who come into the hospital, and yes, you can wear just a regular face mask if you're a guest or a patient. I had a patient with, I had a visit today with my neurosurgeon, You had to, one, they did screening on the phone still. Two, you had to wear a mask to get into the building. You had to wear a mask while you were in the doc's office and when you were in the exam room. So my neurosurgeon is following all the protocols that we did before. The ADA says we don't need to screen our patients anymore on the phone. We don't need to really screen them when they show up to the clinic. We actually still do screening when they show up to this building, and we do some screening in the oral health center. And we can actually, since we have access to the EMR, we look to see if they are up to date with their vaccines. And if they're not, we talk to them about that. There needs to be more research and looking into this diabetes and COVID-19. We already have enough of it in the United States, enough of diabetes, and actually we've had too much COVID. And so what can we do to keep people healthy? So CDC came up with some new guidelines and what we basically do and how COVID is in our community. What they really do is they want to see if your transmission levels are high, your community levels are high, they want you to take serious precautions. If you are seeing somebody who's reported symptoms, you want to take serious precautions. But now they're not doing screening in the offices as much as they were before. It's just based on high rates of transmission. The CDC recognized that between vaccination and immunity from people getting COVID, because we're having more effective treatments, less people are suffering from severe outcomes from COVID infection. So it's not as serious an illness. Do you need to continue to mask? My staff is masking. The only time we are not masking is if you're in a private office. If you walk in a hallway where people are being treated, you are masked. If you're at our front desk, you are masked. If you're in an operatory, you're more than masked, and we'll go into that. Because so many people are asymptomatic and so many of our procedures generate an aerosol, we still can be exposed to COVID. So we're still using all of the things that we used before. Remember earlier on in this pandemic, up to 50% of people were either asymptomatic or pre-symptomatic when they went and saw the dentist or the dental hygienist or the physician. They didn't know that they had it and were still transmitting the disease. And so again, I think the goal is not to be locked up in your house and try to get zero COVID, but we want to keep the numbers low. And so that means, how are we going to treat our waiting rooms? How are we going to treat our operatories? And what steps are we going to take? When to wear a mask, this is their latest update. When community transmission levels are not high, offices can choose not to have patients or staff wear masks while in the office. When community transmission levels are high, both patients and staff should wear masks in the office. During those time periods, make sure you wear a mask for any face-to-face contact with patients. And if you're using aerosol generating procedure, you need to have on a face-fitting respirator, such as an N95. So those are just some of the things. I put Lenny Kay on there. She's a colleague of mine in Georgia. She's basically the OSHA goddess out here and a dear friend of mine. PPE, when working on screen patients who are not suspected of having COVID and community transmission levels are not high, we should follow standard precautions like we always have. Do I agree with that statement? And my answer is I actually do not. Yes, you should wear a mask, a face mask, but if you're in an area that has any transmission and you are working with aerosol generating procedures, wear a face-fitting respirator, such as an N95. Just now, I have one staff person, a remarkable dental assistant who has very bad asthma. The CDC does have an alternative to wearing the face-fitting respirator, which is wearing a level 1 or 2 mask. What's the difference between a mask or a respirator? Respirators will keep out 95% of the aerosol particles. A mask, the difference between level 1 and level 3, a level 3 mask is more fluid resistant. Aerosols still get through it. What my staff does, which I think is sort of interesting, you'll see a recommendation where if there are no issues with masking, you can keep the same mask on all day. I think that's a bit of a problem. But what my staff does is that they wear the face-fitting respirator and they wear a level 1 mask over that. And when they're working on patients, they have a shield over that. So they take the level 1 mask off, they take the shield off, of course, but they keep the N95 on until it may get wet. And I talk, and when I talk, there is some spittle. So I actually change my respirators out a little bit more frequently because I know they're getting wet. When an N95 face-fitting respirator gets wet, it is no longer functional. It doesn't do its job. Don't write on an N95 respirator, which was something that was being done earlier in the pandemic. In communities and levels with high transmission levels, respirators should be used when performing aerosol generating procedures. Again, I agree with that statement. However, I guess the only time I would be happy with not wearing a face-fitting respirator would be for maybe a wax try-in, but my staff is wearing them at all times. I don't want, my number one job at this point in my career, other than keeping the place funded, is to making sure that my patients and staff are safe, that everybody has the safest dental visit, and that my staff remains healthy throughout this pandemic. And knock on wood, so far there have been no cases of transmission among my staff, not even at home. We've had outbreaks in our pharmacy department. We've had outbreaks in primary care. They were told that during the high point of the pandemic, they had to wear face shields. I thought it was hysterical because they said they really couldn't see the patient. We've been wearing face shields for a very long period of time. I think probably for decades at this point, and are doing things with like endodontics, where you're working in very small openings. And so I think when I heard that from primary care, I thought it was sort of interesting. Also, our primary care colleagues weren't used to putting on gowns. They weren't used to putting on PPE unless they were at the hospital. Watching, and this is very early in the pandemic, and I wish I would have filmed it, watching our primary care advanced practice providers, our nurse practitioners and our PAs and our medical assistants learn how to put on the gown was worth like a funny video. It was absolutely hysterical watching them try to do it because they weren't as used to wearing PPE as we do. And I think as dental health care providers, whether you're an assistant or a dental hygienist, dental therapist, dentist, we have been protecting ourselves for years because of bloodborne pathogens. And so we're used to wearing PPE. I think the new thing for us is that we're dealing with airborne transmission. Have we had an issue with airborne transmission for a very long time? Probably. People have had the flu and they've had other colds, and you get them. And so you still need to do all the things that we always do: hand washing, hand hygiene. I know that when it comes to infection control, I think the CDC's hand hygiene guidelines are really not very good because they say wash your hands for 20 seconds. Well, or saying happy birthday twice or whatever. I think what people really need to do at this point is to make sure you follow and get all the areas of your hands. One of the issues we have is with nail hygiene, that SMS stuff. I've learned more about nails in the last couple of years than I ever knew before. Gel nails are a no-go because things grow underneath it. The length of your nails, you shouldn't be able to see the nails when your hands are facing forward. So we wear close-fitting eye protection. Readers are not eye protection. Regular glasses are not eye protection. Loupes usually have side protection, so that's good eye protection. Face shields are good eye protection. And when talking about eye protection, never forget the patient. Always have the patient with eye protection on as well, just in case like an endophile happened with that Jen's case that's been very famous, or something happens that you drop something. And so we just want to make sure that we have the safest possible visit. However, the Association for Professionals in Infection Control and Epidemiology, APIC, which there are several members of OSAP that are members of APIC, they strongly urge their 15,000 members to uphold a mandatory mask requirement policy for healthcare employees in all patient care areas. So in my waiting room, I have a much larger waiting room now in my new clinic that I'm running. And so patients can sit pretty far apart. We're still doing some distancing. We're still making sure our patients have masks on. I didn't want it. I wanted to have an open front desk when I initially designed this to make it more welcoming to patients. Now I have sneeze guards or whatever they're called, and my front desk staff has on a mask, and they check to make sure our patients are wearing a mask. These are not chin diapers. They need to cover the nose and the mouth. So we want to really make sure that we have the safest environment. The recommendation came after the recent update from US CDC that advises healthcare facilities to use community transmission levels of SARS-CoV-2 as a guide when source control through masking is necessary. APEC emphasized that requiring a mask of everyone who enters a healthcare setting ensures the safest environment for patients. I do completely agree with this. I think that our patients should be masked. We should have on those face-fitting respirators when doing aerosol generating procedures. To be frankly honest, when I'm walking through the clinic and I'm not at an operatory, I am wearing a KN95. I will let you know that KN95s are no longer recognized as an OSHA recommended mask to wear when doing aerosol generating procedures. They want an N95 or greater. So just so you know, doing aerosol generating procedures with a KN95 is not recommended any longer. It's also important to know that you need to have every member of your staff that is around aerosol generating procedures to have fit testing for their N95 or their face fitting respirator. And this has to happen whether it depends, it doesn't matter if you change brands. So you say you were using brand A and then you switch to brand B, you have to be fit tested for the new brand. And so we actually, during earlier part of the pandemic, we had a hard time finding those N95 face-fitting respirators. I think that's one of the reasons that we heard out of Washington not to wear the N95 if you were a person on the street, because there was literally a shortage and people were sterilizing with UVC their face-fitting respirators and all that stuff was going on. So I think when people say, well, they said, don't wear these masks, they were literally trying to make sure that we as dental healthcare workers actually had access to masks. I love this slide. It's one of my favorite slides. It actually works for all of the different kinds of diseases we'll be talking about today, with one exception. So it's a Swiss cheese model, and you can see that if you only had a portion of this, virus particles will be able to get through. So there are personal responsibilities, such as physical distancing, masking, hand hygiene, cough etiquette. I can't believe I was in a dental meeting just a couple days ago, and there were people coughing into their hands. It was like, do you not pay attention? You are a dentist. You are a leader. You're a dental director. Why are you coughing into your hand? Cough into your elbow. If you cough into your hands, say you just do it out of reflex, then make sure you have an alcohol-based hand sanitizer. One other point about hand sanitizers versus soap and water that I like to talk about. If your hands are clean, the hand sanitizers are actually more efficient than washing your hands with soap and water. It's also use a liquid soap if you are using soap and water, because bar soaps actually can grow bacteria. So it's really important that to make sure you're using appropriate hand hygiene, appropriate donning and doffing, those kinds of things, and avoid touching your face. And it's amazing how many times a day people touch their face. If crowded, in a crowded area, limits your time. Other things that are shared responsibility is making sure that you are getting that you're testing on a regular basis if you think you've been exposed. Ventilation, outdoor air filtration, if possible. It is not possible. I'm on the 6th floor of a building. since we are at a hospital, you can't open these windows. Regretfully, several years ago, we literally had a patient who jumped out of the 7th floor at the hospital. So we definitely make sure that all of the windows are locked. We can't have that kind of stuff because that means a CMS visit and a Joint Commission visit. Government messaging when it's appropriate, and financial support are appropriate when appropriate. Quarantine and isolation, those times have been removed. And then vaccines. So these are all the different steps that if we did, each layer will make sure that we are more protected and can get this under control. And I think we've done a good job between getting natural immunity, vaccinations, wearing a mask when appropriate. Do I think we need to wear a mask in a football stadium? I'm a big, hope I don't offend anybody, I'm a big Tampa Bay Buccaneer fan. That's where I grew up in Tampa Bay while they were trying to get the team. My first year in college, I went to Emory. Our football team is still undefeated. And so I grew up as a Tampa Bay fan. If I'm watching the Falcons versus the Bucks, I'm most likely not going to wear a mask, although with all that screaming and yelling, I could be exposed. And there is one case where there was some kind of outdoor activity where they think there was outdoor transmission. I think as long as you've got a lot of air around you, I think you're pretty safe. Remember though that it doesn't take much, but I'm not going to a football game mask, I'll be honest with you. So recommended routine infection prevention and control practices during this pandemic. Establish a process to make sure everyone entering the facility is aware of recommended actions to prevent transmission to others. If they have any of the following 3 criteria: a positive viral test for SARS-CoV-2, symptoms of COVID-2, or close contact, and that could mean a total of 15 minutes over a period of time around somebody who is infected. Source control for healthcare providers include the NIOSH approved. NIOSH no longer approves that KN95, just to emphasize that point. A NIOSH approved particulate face fitting respirator with N95 filters or higher. A respirator approved under standards used in other countries that are similar to a NIOSH approved N95 face fitting respirator. They should not be used instead of a NIOSH approved respirator when respiratory protection is indicated. So translated, when we're doing aerosol generator procedures, we need to be using an N95, a NIOSH approved N95. I don't think we have as much problem as we did earlier in the pandemic when there were fake versions that were going out. There literally were knockoffs that did not have the 95 filtering performance. A barrier face covering that meets the standard requirements, including workplace performance and workplace performance plus mask, or a well-fitting face mask. And this is an alternative that I do. Like I said, I have one staff member who does wear the face mask and a shield because she is such a bad asthmatic. When solely used for source control, any of the following options listed above could be used. So it could be face mask, face fitting respirator, etc. It's the entire SIP, unless it becomes soiled, damaged, hard to breathe through. An N95 is hard enough to breathe through. And as I mentioned, if it gets wet, and that could be from the inside, change it out. If they are used during the care of a patient for which a NIOSH approved respirator or face mask is indicated for personal protective equipment, they should be removed and discarded after patient care encountered, and a new one should be donned. And I'm not going to go over donning and doffing because we have so many diseases to cover today. When SARS-CoV-2 community transmission levels are high, and there are some areas in Arizona that I showed you where they are high, source control is recommended for everyone in a healthcare setting when they are in areas of a healthcare facility where they could encounter patients. Healthcare providers could choose not to wear source control when there are well-defined areas that are restricted from patient access, such as staff meeting rooms. When my staff meets and I have a nice sized conference room in the new Oral Health Center, we are masked. If they do not otherwise meet criteria described below and community transmission are not high. When SARS-CoV-2 community transmission levels are not high, healthcare facilities could choose, and I think that's the big word, could choose not to require universal source control. So before I even go on to the next disease, COVID levels might be reduced, but we have been masked for the better part of a few years. Our flu levels, which used to completely overtake my hospital, where we have to bring in these portable emergency departments like these enormous buses from North Carolina because our hospital would be past 100% full. We had to have a place to put our patients. And that was just due to the flu. So wearing a mask, just because COVID levels are low, is not the only reason that you shouldn't wear a mask. Our flu levels are off the chain right now, and they happened earlier than they normally do. So just because the SARS-CoV-2 levels are not high, other infectious airborne diseases can be, and you need to keep an eye on that. And we'll talk about how you can look at flu view, hard to say, and see where Arizona is or places you might be traveling to. If source control is not universally required, it remains recommended for individuals in healthcare settings who have suspected or confirmed SARS-CoV-2 infection or other respiratory infections, those who might have a runny nose, cough, or sneeze, had close contact, we know that issue, and reside or work in a unit of a facility where you have an outbreak. Again, I work in an infectious disease program. We're here to protect the providers and the staff. The U.S. public health emergency has been extended to January 11th, 2023. This is the 12th time since January 21, 2020 that it has been renewed. Several response efforts hinge on the emergency declarations, such as vaccines being covered by the government. It allows the government more regulatory and funding flexibility. But as you can see, it is going to end in January if during this month we can keep our levels low. So that was everything you probably have heard about COVID before and maybe didn't want to hear again, but it's always good to get some of that information across. And now we're going to talk about the flu. Get the flu vaccine before the flu gets you. So at Grady Health System, we have annual blood testing, fit testing, just for some goals. So we look at our lipid levels, our hemoglobin A1C levels, our blood pressure, and that's when we get our flu shots. So I waited on Grady to get our flu shot. It was, I guess it was in late October when this happened. I got the flu shot on a Wednesday. Regretfully, my spouse started showing symptoms on Thursday evening and had full-born flu on Friday. I played nurse the entire time. I could have put on a mask in my own home and I chose not to. I ended up with the flu. This is, excuse the language, this is a kick-ass flu. I haven't had it for a long time, but it literally knocked me down for a couple days and it lingered for a couple weeks. So it's really important that people get vaccinated and realize it takes a week or two for the antibodies to kick in. And so I didn't have enough time for my antibodies to kick in. I got kicked. That's one way of wording it. It's sort of interesting that we're having it this week because it is National Influenza Vaccination Week. It's been this week. I haven't really seen much on television, but then again, I've been in an RV and in meetings, so I've been watching much television. Flu season so far, it's here, and early red flags suggest it's on the track to be a very, very bad flu season. The latest data from the CDC's Flu View report shows extraordinarily high numbers of positive flu tests reported to the agency from labs around the country. As of November 5th, nearly 14,000 positive flu tests have been reported, as shown on an orange line on a chart I'm going to show you. That's more than 12 times the number reported at the same time in 2019, before we had COVID in the air. So that's what I think is important. It's 12 times higher that we have at this point than we normally would have in a non-pandemic year. So just look at the red line. That's where we were as far as the number of positive tests. And this is actually in November. That was the latest data that I could find. But you look at the previous seasons and their high peaks were in January. Some of them even begin at the very end of January, a little bit towards the beginning of February. So it's not normal to see this high a level of flu. Is it because we had been so safe so long and we hadn't been exposed to the flu, we hadn't been exposed to much cold and fever, we didn't have many antibodies form, that we were getting hit so hard and so early? It's yet to be determined, but just know it is here. And someone on this call actually put on the chat that they got the flu early and it knocked them down too, so I'm not the only one. So there are all these myths. The number of people who have been vaccinated for the flu is woefully low. Is it because people are vaccinated out? I don't know. I don't know why that you can go into your local grocery store, if they have a pharmacy, or your local pharmacy, and get a flu vaccine. That why it's such a low number. And that part of it is because there are myths. And one of them is if you you can catch the flu from the vaccine. That is the number one myth. And so I have staff who have worked with, some of which for 30 years, believe that that they have gotten the flu shot and then they get the flu. Well, I got the flu shot on a Wednesday. I had the flu the next week. I didn't catch it from the vaccine. I caught it because one, my spouse had the disease. Two, I was taking care of my spouse and not looking out for myself, which there's no way. I mean, my house isn't that large. I wasn't going to catch it. And so, as it says, it takes 1 or 2 weeks for this vaccine to be effective. So even though you get the flu vaccine on a Monday and you have the flu on Wednesday, you did not get it from the vaccine. There is no live virus in the vaccine. Myth number 2, healthy people don't need to be vaccinated. Besides my age and some issues with my spine, I'm relatively healthy. Knocked me down. You don't need to get a flu shot every year. The flu changes and we literally have to try to guess and make sure we have the right strains. And so we look and see what's happening in Australia in the Southern Hemisphere. We try to match that, and apparently we did a good job this year. So we are having the most dominant forms of the flu are contained in this year's vaccine. Another myth, pregnant women can't get a flu shot. The flu shot is highly recommended for pregnant women, as pregnancy can cause immune, heart, and lung changes that increase the risk for flu. People with egg allergies can't get the flu. Well, there is an eggless vaccine now. And even though egg allergies are there, this won't cause that serious of an illness, but there are egg-free vaccines that are available now. If you get the flu, the shot didn't work. No, there are multiple flu strains around the world. It's about 60 to 90% effective. It is not 100% effective like the measles vaccine and the polio vaccine. And you can see there's been some vaccine hesitancy in the Northeast, and measles came back. We've actually even seen polio come back because of some vaccine hesitation. So that is a bit of an issue, but none of the flu vaccines are 100% protective. Getting the flu vaccine is all you need to do to protect yourself from the flu. Well, that's not true as well. You need hand hygiene. You need several different things that you can do to not get the flu. The flu is just a bad cold. No, flu causes temperatures, it causes hospitalizations. It averages 36,000 deaths a year and more than 200,000 hospitalizations. Cold doesn't cause that. Flu can cause GI symptoms like nausea, vomiting, and diarrhea. The term stomach flu is actually a virus. It could be norovirus or something like that, but it really is not a symptom of the flu. You can't spread the flu if you're feeling well. Not true. We know that about 30% of people carrying the flu virus have no symptoms. So asymptomatic spread, just like we see with COVID. If you have a high fever with the flu that lasts more than a day or two, antibiotics might be necessary. As we all know, the flu is a virus and antibiotics don't work. We do have antivirals, and the antivirals should be started as soon as possible. So we do have an influenza surveillance called FluView. It's a FluView. It is hard for me to say. A weekly influenza surveillance report, and it's interactive, so you can go online and see where it is in your state and in your county. So key updates for the week ending November 26, 22, seasonal influenza activity is high and continues to increase across the country. In the clinical lab, 25% positive tests for influenza that week. Public health labs, the most frequently reported virus this week were influenza A, H3N2, which is actually a good thing because our vaccines do protect somewhat against H3N2. And genetic and antigenic characterization are summarized in the report. And so I actually did access this information yesterday. Key points. Seasonal flu activity is high and continues to increase. Of influenza A viruses detected in subtype this season, almost 80% have been influenza A, H3N2, and 21% have been H1N1. And again, H1N1 is also included in this year's vaccine. 2 influenza-associated pediatric deaths reported that week, for a total of 14 pediatric flu deaths reported so far this season. CDC estimates so far this season there have been at least 8.7 million illnesses, 78,000 hospitalizations, and 4,500 deaths from the flu. And this is early on. Remember, 200,000 deaths in the course of the flu on a typical year. The cumulative hospitalization rate in the flu SERVNet system is higher than the rate observed in week 47 during every previous season since 2010 and 11. So it's not just something we've seen in the last couple of years before we saw COVID. This is the highest levels we've seen in over a decade. And I think that is also worrisome. The number of flu hospital admissions reported to the HHS Protect system during week 47 almost doubled compared to week 46. That's significant. The majority of influenza virus tested are in the same genetic subclade as and antigenically similar to the influenza viruses included in this year's vaccine. Great news. All viruses collected and evaluated this season have been susceptible to the available antivirals. Great news. An annual flu vaccine is the best way to protect, but remember the other things we can do. Vaccination helps prevent infection, and it can also prevent serious outcomes that get people to get sick. CDC recommends that everyone ages 6 months and older get a flu vaccine annually. I would say now is a good time to get vaccinated if you haven't already, since it's Vaccine Awareness Week for the flu. If you haven't gotten the vaccine at this point, please do. Because as I've mentioned, this vaccine, this flu is pretty serious disease. There are also prescription flu antivirals that can be used to treat, but they need to be started as soon as possible. And I hesitated. I didn't know if I was having a bad cold, if this was COVID, blah, 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 blah. And I just should have called my doctor, and I did not. I was being hard-headed. Please don't be hard-headed. Take the antiviral because it will shorten the course of the disease and lessen the severity. So if you look at the influenza season ending weeks of 47, so that was November 26th, right around Thanksgiving time, you can see that it is high in Arizona, but it is not the degree that it is in New Mexico and Texas and California, some of your neighboring states. But almost every part of the United States has either high or very high levels of flu activity, with some Alaska, one of the states I haven't been to yet, having a relatively low level. Michigan and the Upper Peninsula are relatively low level, and some of the states up north. But to be frankly honest, most of the country is having high levels of flu outbreak at this point in time. So what about Arizona-specific influenza data? You can actually just select which county you want to look at. So for this, I looked at Maricopa County, and I'll show that in a bit, but these are the state cases. So this is the entire state, the dashboard used from the start of influenza up to the most current week, which was November 27th to December 3rd. Lab confirmed influenza cases reported were up 43%. There were 4,800. Lab confirmed influenza cases reported from the start of the season is 12,700. If you look at Maricopa County, the number of cases reported is 7,151. Again, that is an increase of 48%. So you're basically at the state level, realizing that Maricopa County is the most populous county in the state. Vaccine efficacy rate. There's good news from the Southern Hemisphere that among countries that just concluded their flu season, Chile, for example, found the flu vaccine is a good match for the current strain. They're reporting a 50% efficacy rate. So that sort of is not, we're not going to not get the disease, but it will have antibodies that will make the disease much less serious. Only 28% of Americans are vaccinated against the flu. This is almost 10 percentage points lower than pre-pandemic levels. The slide says it's frustrating. That's another reason that we're staying masked, because we have such high levels of flu in the area, and 30% of people who have the flu could be asymptomatic. It doesn't mean you can't catch it from them. So we're still staying masked. We're still staying all the precautions. I still have my chairside extraoral evacuation systems in use. I still have portable HEPA filtration in every one of my operatories. In my larger rooms, I have something called a virus killer. We don't have that facing the waiting room. We don't want to scare the hell out of our patients that we're going to kill them, but we do have it in the room. We have it in the front desk area. We have it in the group room and in the doctor room. So all of the different larger areas have these bigger units that can handle larger spaces. So I'm protecting against COVID, and I'm protecting against the flu. Next up is RSV. There is a chat question, so let me see before I get there. We've got the wall-mounted virus killers in our house. Very good, Chris. Love those things. I'm going to close it out. Let's go to our next disease of the moment that's out there, but it's just amazing how much is going on all at the same time. So we're going to talk about RSV, if I can get the slide to move. Whoops, back slide. There we go. Make sure I'm on the right slide. There we go. Healthcare providers should consider RSV in patients with respiratory illness, particularly during the RSV season. Apparently, we're in there. This is not a new virus. People keep on thinking we're seeing all these new viruses. Only new virus that I'm aware of that's out there is SARS-CoV-2 and their variants. So this was discovered in 1956. It's actually older than me. I can't say that about much stuff, and has since been recognized as one of the most common causes of childhood illness. It causes annual outbreaks of respiratory illness in all age groups, but it's definitely been filling up our children's hospitals. In most regions of the US, RSV circulation starts in the fall and peaks in the winter, but the timing and severity of RSV season in a given community can vary from year to year. So we've already seen it start. We've already seen how significant it is. If you dare turn on the news these days, and for many times I really don't look at it anymore because just not a whole lot of good news. I mean, when you come down to it, there's wars going on, gas prices, inflation, whatever it is, they like to get us all stirred up all the time. But if you turn on the news, you can see that these children's hospitals around the country are being overwhelmed. Scientists are developing vaccines, but we don't have that yet. They're looking at monoclonal antibodies and antiviral therapies to help protect infants and young children, pregnant women, and older adults from severe RSV infection. Each year in the US, RSV leads to approximately 2.1 million outpatient visits amongst children younger than 5 years old. 58 to 80,000 hospitalizations amongst children younger than 5 years old, 60 to 120,000 hospitalizations amongst adults 65 years and older, 6 to 10,000 deaths amongst adults 65 years and older, and 100 to 300 deaths in children younger than 5 years of old. This actually comes from the CDC as well. So if you look at the percent positive data, we have some antigen data, we have some actual catching the virus, and all of the numbers as of the end of October, early November were peaking up. And they were going up at a very high level, which is really what caused the level of concern. If we look at Arizona's RSV weekly report, and again, this is something that is very easy to find on the CDC's website, lab confirmed RSV cases reported, the current complete calendar week was down 5.1%, but there were still 1,500 cases. Total lab confirmed RSV cases in the state of Arizona was 8,569. If we look at a different county, and here I looked at Navajo County, RSV cases reported were 321, which was a very significant increase of what they saw the week before, almost a 59% increase. I understand it's not as populated, but still, that is a huge increase. And we don't want our little kids and older people such as myself getting ill and ending up in the hospital. So how do you do a clinical description and diagnose in infants and young children? And I don't have any kids, so I really have no expertise in that. And gratefully, mother-to-child transmission of HIV is not something we see all that often, although Georgia has not eliminated mother-to-child transmission of HIV. Cuba, that little country to the south, has. They were the first country in the world to eliminate mother-to-child transmission. Sort of an interesting little fact there. RSV infection can cause a variety of respiratory illnesses in infants and young children. Most commonly causes a cold-like illness, but can also lead to lower respiratory infections. And that's what we saw at the beginning of COVID. When you were talking about your alpha variants and your delta variants, they actually cause lower respiratory infections. That's why you kept on hearing all these calls for respirators around the country. We didn't have enough respirators, that we needed respirators from the federal government. Now, COVID is really causing more upper respiratory infections, which is why you're not hearing those constant calls for respirators. But RSV can lead to bronchiolitis and pneumonia. Infants and young children with RSV infection may have a runny nose, a decrease in appetite, and before other symptoms appears. Cough usually develops 1 to 3 days later. Soon after the cough, sneezing, fever, and wheezing may occur. And in very young infants, irritability, decreased activity, and/or apnea may be only symptoms of infection. So maybe the same as for older people. It's like, if maybe I'm irritable or I'm not having as much activity. No, it's not that. It's just getting older. In older adults, what do we see? Or with other chronic medical conditions. Adults who get infected with RSV usually have mild or no symptoms. Symptoms are usually consistent with an upper respiratory tract infection, which can include a runny nose, a sore throat, cough, headache, fatigue, and fever. So if you got this, what's the first thing you do is test for COVID. Make sure you don't have COVID. Then the next step is to go see your physician or your primary care provider. The disease usually lasts less than 5 days. As I said, this flu hung on for 2 weeks. It was a joy. I got the flu on Monday. I was in bed, did not move. On Tuesday, I could move. But I had to get better because I had to go to the Board of Dentistry, because Georgia was one of the 2 states in the country that did not allow dental hygienists to anesthetize their patients. And that vote was coming up, and I helped write the piece of legislation or the rule for it. And so I wore an N95, literally wore an N95 to the Georgia Board of Dentistry meeting as opposed to staying home. The general rule of thumb, if you have staff people or yourself, if you are sick, you really should stay home. You don't want to transmit it to other. And when we have our lower paid employees who don't have a lot of time off or sick time accrued, they tend to come to work. And so we really have to encourage it, maybe give a free day off or whatever. We need to encourage people, if they're sick, to stay home and not spread disease. Some adults, however, may have more severe symptoms consistent with a lower respiratory tract infection, such as pneumonia. Those at risk for severe illness include older adults, especially those 65 years and older, adults with chronic lung or heart disease, adults with weakened immune systems, such as my patient population. RSV can sometimes also lead to exacerbation of serious conditions such as asthma, COPD, and congestive heart failure. Prophylaxis in high-risk infants and young children. There is a monoclonal antibody recommended by the American Academy of Pediatrics to be administered to high-risk infants and children likely to benefit from immunoprophylaxis based on gestational age and certain underlying medical conditions. It is given in a monthly intramuscular injection during the RSV season, which generally starts in the fall and peaks in winter in most locations in the US. COVID-19 vaccination does not increase the risk of RSV infection. So social media does have a lot of wacky news. So please don't believe everything you see unless it's on hivgen.org, because that's coming from me. No, don't believe everything you read on social media, because there are bad data. There were posts claiming that Pfizer and Moderna clinical trial results shows that their COVID-19 shots put children at greater risk of contracting RSV. It is false. Experts say the allegation is a misinterpretation of the data. No such risk has been identified at the population level, and infants and toddler vaccination rates are too low to correlate with the uptick in RSV cases in Canada and the US. So this is a screenshot of an Instagram post that was taken in November this year. So I think the names are on there if you can read them. Evidence suggests COVID shots are responsible for soaring RSV cases throughout the US and Canada. False. That is a definite false. So on to the next one, which is Mpox. I don't know why that said RSV. So Mpox, previously known as monkeypox, but the WHO has changed the name and the US has adopted the name because they thought that monkeypox was too stigmatizing. New Mpox cases have declined by 85% since the August peak, and here's why. And these are some important things I need to bring up. Experts attribute the drop to a variety of factors. The vaccine, which has a much higher efficacy rate than the flu vaccine, is at 85%. It helps slow the virus down. People who were most at risk to getting this disease, men who had sex with men, reduced their number of partners following the rise in cases in the wake of large gatherings around Pride in the month of June. And the virus spread by close skin-to-skin contact was self-limiting, unlike airborne coronavirus or flu, finding fewer places to spread as potential hosts reduced their exposure and the vaccine produced effective. So what did we see? We saw people who were at risk lining up to get vaccinated. We saw people who were at risk reducing the number of their partners. And the Washington office of Mpox, which is run by Dr. Dimitri, it's still there because there is some still people who, we saw about 48% of the people who had Mpox also had HIV. And we still have a lot of undiagnosed HIV in our community. And we have people who are not getting the message about Mpox. So even though the numbers are lower, we're still not done with the job. But we've shown that behavior change plus vaccination can be effective public health prevention messaging. So this is just a graph showing the daily Mpox cases reported over a 7-day average. You can see how it peaked in July and then it started tail spinning, and it's really down to those really low numbers that we were seeing in the beginning of this epidemic. this is something that's interesting, Mpox infection from an occupational needle stick. So how many documented cases are there of a dental healthcare worker seroconverting after an exposure to HIV in the dental setting? And the answer is 0. There's never been a documented case of a dental healthcare worker seroconverting after an exposure in the dental setting. Even in the period of U equals U, undetectable means untransmissible, meaning if you have an undetectable viral load or a viral load even less than 200, you cannot sexually transmit HIV. However, if we have an exposure in the dental setting and we know the person's status, we do start post-exposure prophylaxis as soon as possible, because we don't have the data and we're never going to really have the data about needle sticks and HIV seroconversion when you know the status. So that's important. But there was one case of Mpox being transmitted through an occupational exposure. It was not a dental healthcare worker, it was a nurse. There has been one documented case of HIV post-occupational exposure since the year 2000, and that was a research lab technician who was working with HIV-infected blood who had a serious exposure. So there's only that one case of HIV transmission. There's one case of a needle stick with Mpox transmission. In July of this year, a Florida County Health Department received notification of an emergency department nurse who was exposed to Mpox through a needle stick that occurred earlier that day. While she was obtaining swabs from a patient with suspected Mpox, the nurse used a needle to create an opening in the vesicular lesion to facilitate direct contact of the swab with the lesion. The needle stick occurred when recapping the used needle by hand before disposal. Just writing that sentence hurt me. We don't use recapping, two-handed recapping. We don't do it in dental. Medical has safety needles. I mean, where it's virtually impossible to get an exposure. But what I hear every day on our safety calls at our hospital is how many needle sticks occur during a day. When I gave blood today because I had a pre-op visit, they had a butterfly that was a safety butterfly. Maybe we're not using them in the hospital, but maybe we should switch. Even though we are a public health hospital and the only level 1 trauma center in the area, maybe that's a way to reduce the number of needle sticks, and I will bring it up on a medical executive committee. But when you do recapping by hand, it caused a break in the skin of the index finger through her gloved hand, accompanied by a small amount of bleeding. The wound was immediately washed with soap and water, drenched with betadine and a septic solution, which is 10% povidone iodine. The incident was promptly reported to the hospital's infection control practitioner and occupational health department and to the county's health department. Later that day, the lesion swab collected from the patient by the nurse tested positive for Mpox using real-time PCR assay at the Florida Department of Health. Within approximately 15 hours of the incident, the nurse, who had no relevant medical history or previous orthopoxvirus vaccination, received the first of her 2-dose Mpox vaccination as a series of post-exposure prophylaxis. 10 days after their exposure, a single skin lesion formed at the site of the needle stick. The nurse immediately began isolating at home and kept the lesion covered until it had crusted over. The scab had fallen off and a new layer of skin had formed the lesion 19 days later. So this was a workman comp issue that the hospital had to deal with, but don't recap needles. That's the biggest thing. We have devices, scoop techniques, all sorts of ways to prevent needle sticks in our settings. Apart from the single lesion at the puncture site, no additional lesions or other clinical signs or symptoms were reported, and the antiviral was not indicated. No secondary cases were identified. This report was the first occupationally acquired Mpox infection in the U.S. healthcare worker during this outbreak. CDC advises against unroofing, opening, or aspirating mpox lesions with sharp instruments and recapping use after needles because of the risk of sharp injuries. I also do site visits. One point about sharps containers, when they're 3/4 full, they're full and must be changed out. I've done some site visits at some dental schools and some dental programs around the country, and I see people trying to save money by filling them to the rim. I know you don't do that in Arizona, but that is a way that people can actually get a needle stick. And then you don't know the source person, so you have to basically start post-exposure prophylaxis. So I finished everything you wanted to know about all these different diseases in record time, 1 hour and 30 minutes. And I'm going to stop sharing my screen to see if there are any questions that people might have. The Stump the Dentist portion of today's presentation.
I have a thought, David. I know you had mentioned the efficacy of the flu vaccine this year was about 49–50%. Do you know offhand what the usual efficacy rate is? I know
it is usually less than 80, greater than 40, and that's if they get it right.
Right.
So this year they actually got it right, which means I don't understand that they got it right, but we really only have 48% efficacy, so I don't get that. And so if all my members of my staff in the hospital, they have to get the flu shot. That's one of your mandated things that you have to have. Is another reason why masking is still so important, because we have the flu out there. And if you're since the flu hit me that hard, I decided I'm no longer 64.5. I'm just going to say I'm 65 and be done with it and take these things seriously. I have no desire to end up in a hospital outside of this little outpatient procedure to fix my back.
Yeah, we have a mandate at our health system as well. I don't know about the rest of the group, but we have flu vaccine mandate for everyone. There are some minor exceptions that are allowed, but that all goes through our employee health and wellness group. But I think we're currently, our deadline was 12/1, and I think we're at like 99.6% compliance at this point. Like it's been a priority in our healthcare system,
which is excellent. And there are religious reasons,
yeah,
religious exemptions for it. The egg allergy thing, since they are non-egg based now, that isn't a good reason anymore. So it took some convincing. As you know, Chris, I've been here 30 years in this program. I've seen every one of our medical directors try to do that mist buffing thing about the flu vaccine. And to this day, they only take it because they know they have to. Because I have several staff members who say, well, I took the vaccine and then I got the flu. Well, I took the vaccine and I got the flu. But it takes a while to build up the antibodies. Good question, and 99.6 is pretty outstanding. Great job.
It's only a week late, so.
Only a week late.
Yeah.
Listen, this flu hit early and it hit hard. I mean, let's be honest. Grady is usually earlier on these things. And we do have these, I forget what the term is, but we have these mandated things. And if you participate in it, your health insurance is less. Yeah. So everybody participates in it. But I wish I would have gotten the flu. It's just, if you get the flu vaccine outside of the health system, it becomes more of a problem getting it in the system. So which is why I waited, and I won't do that again.
Well, there's also some talk of like, if we get it too early in the system, the immunity might wane as the season goes on. Isn't there some concern for that as well?
Excellent point. Normally when we got the vaccine, because normally December and January are your big months.
Yeah.
Those are your big months of flu. And so getting it in early October, you might not be able to be protected through January. So again, Chris, on target.
Well, we got it early, so
I'm giving you the mouse. There you go.
Perfect.
Good job. Did you like how I pulled in that Arizona data?
I did. I appreciated it quite a bit.
There you go. And those tools, anybody can find this stuff. I mean, all of this information is really easy to track. You can look at your county level to see what your flu is, depending on that's your flu rates are, your RSV rates are, your COVID rates are. You can check just by simply going onto the CDC's website and look at their flu view, it's a hard thing to say, and your COVID areas and things of that sort.
I'd be curious if anyone else in the group is seeing sort of the uptick that some of us are. I know, like for our hospital system, we've seen an uptick in the three in COVID and flu and RSV, but our RSV numbers are nothing like what we've seen on the East Coast and some of these other urban areas. But Valleywise has had certainly an uptick, just not as big, and we keep saying yet. So I'd be curious what everyone else's experiences have been.
This is Brianna Hillier. So down here, I think our hospital's kind of we're pretty rural. Our hospital is nice, but not a lot of people go to it, honestly. But we meet once a month. The providers at Chiricahua meet once a month with an infectious disease doctor based out of TMC, so out of Tucson. And we have a virtual chat with him. And he said that they're getting to the point right now. So he's based out of Tucson at the hospital, but where if you test negative for COVID and flu, they're kind of assuming it's RSV for adults as well. And it's harder to test for adults, obviously, but what he said last month was that the hospital beds are at capacity to say that there are actually beds available. Like you're staring at an empty bed, but there is no nurse to help take care of the patient. So that's where he was like, it's, and TMC's ratio was like 4-to-1, 4 nurses to 1, 4 patients to 1 nurse. And UMC's or Banner's was 6-to-1. And so they're just dealing a lot with, they just don't have the staff to help take care of the patients. But that's us down here. We've seen a lot of flu. I actually, like I said, I put in the chat, I tested negative twice. I thought for sure it was COVID. It just felt like it. And it was negative. And then I had a rapid flu that was negative. And I'm a part of a CDC study, the AZ Heroes. I don't know if any of you are, but yeah, so I did that. It's a 4th swab in 24 hours. And I'm like, well, I might as well get paid for one of these. But it's not going to tell me anything I don't know. And then 4 days later, it came back positive for flu. And I'm like, well, that actually made a lot of sense. But oh yeah, left and right and kids, which means providers are out because they have to take care of their kids. Exactly. There's nowhere to reschedule patients, but yeah, that's us down here.
I'll be visiting Tucson with Chris. We might be there.
For OSAP next summer, right?
Yeah.
Yeah.
I'm actually looking forward to being there and being able to walk this time.
That's right. Oh God.
That's a great conference. Beautiful location too.
I already said that I'm associated with the organization, but it is an incredible conference. And yeah. I know this long-haired speaker who's going to be talking about infectious diseases, emerging ones. I don't know this guy. I'm looking forward to doing that and having a table. What I'm really proud about OSAP is they've taken FQHCs, FQHC likes. They're looking at this enormous network of federally qualified health centers and starting to focus there because we know that there's need. And that's something that my work sister, Helene Bednarsh, and I have been preaching for a long time because it's part of the public health. So I think it's very important. I wonder why you tested positive, why it took so many days for you to test positive.
The send out, I swabbed the same day as I did my rapid, but I didn't find out results because it was sent, I swab on a Wednesday, which was the day before Thanksgiving. And then they didn't have anybody in the lab to notify me until Monday. So I think traditionally, and it depends on the lab. There's a couple labs that this study like the CDC will use. I know one's in Wisconsin. So it has to get there and then, right. Process. But traditionally with the lower, it used to take, like we all know, 7 to 10 days because the labs were just inundated. Right now it's taking about 2 to 3. And so this time it took me about 5 because I just, it was the holiday. So, but my docs that I work with, the clinicians I work with as far as medical, we do not do send out flus, I guess, at our clinic anymore. We just kind of rely on rapid. And I've been talking with a couple nurse practitioners and docs, because they're like, it's so tricky now because, 5-6 years ago, even you used to, if it looked like flu, you just treated it. But now, now you've got to get, you want that positive result, especially because side effects related with Tamiflu, which are not guaranteed. But so anyway, that's she's like, we used to just treat it. And now we trust these tests, but they were like, I would definitely trust your send out one that went to the lab. Like, it's anyway.
Yeah, well, it was the same thing. By the time I got my flu results back, I thought it was too late to start Tamiflu.
Me too. Yep. And
So our hospital, we lost one of the other level 1 trauma centers that is located in a low resource part of town near my hospital, closed. It was bought by a for-profit company and they closed it. And so we are building out 230 beds. If you look at our census, we have been over 100% occupancy before they closed. And so we're more than 100% occupancy. The nursing costs right now, because of COVID, went through the roof because of traveling nursing. And it's caused some, in your public health systems, it's caused some great financial strain. We were just sailing along fine and dandy, and then COVID came, and the black, beautiful, we're above the line, it's now red again. But the state's helping us out. Any other questions? So keep doing your fabulous things that you're doing to stay safe and healthy. See, somebody just put, I talked, he put on a mask and he's in his office. So it is important. We want everyone to have a wonderful holiday season. I think we're all tired of being locked up. Not necessarily locked up, but I'm beginning the part where I only recognize people from their eyes and their hair. It's like people are worried about their smile. It's like, well, whoever gets to see it, it's like, don't worry, we'll get it fixed. So I'm grateful for the invitation and the ability to give this little presentation. And I'm glad it all worked out because I didn't have internet access yesterday. My computer went on the Pritz last night. And I had my pre-op visit this morning, so I had one little section I needed to finish where you might have seen the typos.
No, yeah, I'm so glad it worked out. And this was very informative. Like, I've learned a lot from every disease. Like, I don't work in the clinic, but I'm just like, what? This is so much.
Well,
So,
thank you
that's
all for
awesome.
hanging in there. I think you get a break now, right? And then there's a meeting, and I don't know what's next for me.
we have a retention presentation in a little bit.
Oh, that's cool. Well, thank you, Alan. It was my pleasure. I as you can see, I like to talk.
Thank you so much, Dr. Resnick.
All right,
Thanks,
you
Dave.
take care, and I'll get you that paperwork in.
Okay, sounds great.
All right, bye-bye, everyone.
Bye.
Thanks so much.
All right, so since we ended early, we could take a longer lunch break. Just be back by 12:30. I'm applying for the continuing dental education for Dr. Resnick's presentation, so I'll have more info out on Monday. So be back by 12:30 and we'll continue the meeting.